Hi, I'm Oliver Corneli from the University of Cologne in Germany. And today I'd like to present on One World One Guideline, and that is a program of the ECMM, but this focus today is on cryptococcosis only. This is my transparency declaration. Cryptococcosis guideline, we from the ECMM team up with the IDIM, the International Society for Human and Animal Mycology, because they have a worldwide distribution and network, and we need all the network to produce guidelines that are really useful. And you can see that we already did choose 5 guideline coordinators given on the slide from Europe, Asia, Africa, the Americas, and we're now choosing currently another guideline coordinator. Could be from Latin America, could be from Australia, we will see. For the guideline, we define contributorship versus authorship. And that means that we have the usual well-known criteria that define an author that have been set forth by the ICMJE, the International Conference of Medical Journal Editors. But then for the purpose of the guideline, ECMM added, together with IDIM, 2 more criteria, and that is number 5, responsiveness throughout the guideline process, because we want to be really fast, and we have proven that we can do a guideline within 1 year. We did so with the mucormycosis guideline that recently was published. And number 6 is all of us who want to contribute to the guideline need to receive a training, and that would be a training on the ECMM guideline process, practically this very video. Contributors are individuals who do not meet all requirements of authorship on that slide, but have contributed significantly to the work. Speaking about guidelines and speaking about timelines, so this is actually a very important table, although not yet populated, but we will soon start to do so. Practically next week. And then we follow all the actions that are given on that plan, and after a year hopefully we are done. So invitation to potential contributors which are currently being selected and then asked and invited, and then all the other aspects that are given on the slide. I don't want to actually go through them all, but at the end we do have a public consultation and invitation of scientific societies to endorse the guideline or to criticize and help improve the guideline, and then a final review round and the submission of the manuscript. A core aspect of our guideline methodology is that we do 2 independent evaluations. One is for the strength of recommendation and the other one for the quality of evidence, often just referred to SOR and QOE. And that allows, since we see these as independent from each other, that allows that we can go with strong recommendations in the absence of highest quality of evidence. And that might sound strange, but there are 2 examples that will help to understand what is meant. One is the classic example. If we go with a population which is people on airplanes, and the intention is to survive when jumping off that plane, then the intervention obviously is use a parachute. And we say that is very strong recommendation because it's one of the few things where we can all agree on. So it's an A strength of recommendation, but the level of evidence or the quality of evidence is actually only 3 because it has never been tested in a randomized comparison. And for all this, we didn't find a reference. So that tells you that we always go in these tables from left to right, and I would share with you in a moment some more of these tables that have to be populated yet. But before, let's share the second example that is more on the reasonable medical side. A patient with a fever, you want to diagnose fungemia in our case, and you take blood cultures, and of course that is highly recommended, but it has never been tried in a randomized controlled trial. So the best you can get is an A2, but never an A1 recommendation. And I made that reference up because there are many references that we could use for it. Further on, guideline methodology, practically the whole thing today will be on the methods. Going into detail with the strength of recommendation, the SOR, we do have 4 grades, A, B, C and D. And while A means the guideline group strongly supports a recommendation for use, B is a moderate support for a recommendation, grade C is a marginal support in favor of a recommendation, and then D, I always memorize this with don't do it, so D is really a recommendation against a specific intervention in a specific population. The quality of evidence, QOE or LOE if you refer to it as level of evidence, has 3 divisions. Level 1, very easy. It's a properly designed randomized controlled trial, at least one of these, that brings you a recommendation that is supported with the evidence 1. Then let's jump to level 3, because level 3 is another one that is easy to memorize. That is just evidence coming from opinions of respected authorities based on clinical experience, descriptive cases, case studies, smaller reports, or reports of expert committees. So that is the lowest level of evidence that we can have. And everything else, everything that doesn't fall into 1 or 3 is in the big box of level 2, where I'm not going to read a 5-line definition. However, with specifically the level 2 evidence, we need some more details, because otherwise, if you would just see a 2, you don't really know what it exactly means, and it's a pretty diverse area, so there could be a lot of different evidence sources and types within a level 2. That is why ECMM adopted quite some years ago, together with ESCMID, the added index that always needs to go along with every 2 evidence. And the indices are 5 possible indices. One is R for a meta-analysis or systematic review of randomized controlled trials. Then a T means transferred evidence. So you do have a study in the one population, you don't have a study in the other population, but you want to use that evidence for a recommendation in that other population. So it would go with a 2T for transferred evidence between populations. Age stands for the comparator is a historic control. U stands for there is no comparator, it's an uncontrolled study. And A stands for abstract, because sometimes we do have abstract published information only, but not yet the full paper. Sometimes, as we all know, it might take a while until the full paper is written. So we need to make it clear whether it's only abstract evidence, because sometimes you come to a different conclusion between abstract and then full article. We collect all the search strings. So far we don't have any, but as soon as search strings are being used to look for literature for, in this case, cryptococcosis, then the search string will be copied onto that slide. We will have a lot of search strings, and then at the end we will need to consolidate them a bit, but it's always very clear which strings have been used. We do consider patient involvement. For many of the clinical entities that we evaluate and that we give guidance on, there are no patient advocacy groups. That might be different with cryptococcal infection. And we need to actively look for patients who might be involved, or for advocacy or other groups, other organizations that could help identify the most relevant points that should be addressed in the guideline. That brings us to literature access. We are a large group, and there should practically be no article that we cannot access. We will share the PDFs among the author group, and that will be done as follows. All PDFs should be sent to Susanne Blosfeld at University of Cologne, here in my group, and with a suggestion which folder that PDF should go in. I will come to the folders in a moment. All the PDFs will then be stored on a OneDrive, which is located with the German Telekom somewhere here in Germany, and a link will be provided to the authors and contributors of the guideline, and only they will have access to these shared folders. We do not use any review articles and will not store any review articles because we only want to go to the primary original source of information. There might be some exceptions where essential evidence has not been published anywhere else, but that's really a rare thing. And literature that the contributors and authors cannot access, please just send the 8-digit PubMed PMID number to Suzanne, and the team will try to find the article and to provide the PDF to the group. These are the folders where we are asking those contributors who provide articles as PDFs to tell us which folder they should go in. It's pretty small font here, but this is the core and the heart of our platform where we exchange information, and that is where we exchange that slide set that we are currently today looking at as well. More on the methodology. Since we work a lot with PowerPoint slides, it would be fantastic if there were a track changes as we usually use it in texts when writing texts and in Microsoft Windows, for example. So in PowerPoint we don't have that, and that is why we create our own color code. Whatever is black font means that that information has been agreed on in the group. If that is not yet the case, then blue font is being used by the coordinators, and that is for new information the group did not yet agree on, so that you can easily go through the slides as a contributor, find all the blue stuff and make up your mind whether you agree with what is written in blue. Red is author color, so if you are an author and write stuff into the slides, then you use red font. And the coordinator will see the red font, evaluate whether that makes sense, so to say, whether he agrees, whether there is more discussion needed, and if that appears not to be the case, he will convert it into blue color, and that means that whatever is in blue, up for discussion and for agreement finally. Green is just for the convener, and it may come as green in a yellow box, so a real eye catcher. And there are some organizational remarks that pop up during the process. We had that in the past, and that is an addition that we built in during the last year. The coordinators, repeating that one, turns red into blue for discussion, and after agreement then, or sometimes voting if that is necessary, turns the color into black. And black, again, as the first line on this slide says, black is information the group agreed on. How to finalize a slide? Well, one could imagine that everything should be black on that slide, and there are some more instructions on how to finalize, and I'm going to read this rapidly through. So each slide has been or will be allocated to one or more owners in that process, and they are responsible for that slide. And that is why we have many authors, because they share responsibility, but they do have individual slides that they are really asked to look after. So their names can then be found in the notes section of such slide. Once all available information on a topic has been filled in, the slide should be open for discussion. And the owners of the slide inform the coordinators that a specific slide is ready for final review by the group. And that would be turning everything into blue. So the coordinator then aligns any formatting issues, converts red font to blue font, and asks the entire group to agree or disagree or suggest changes on the slide until a certain deadline, usually within a week, for example. And once that deadline is met and all disagreement has been resolved, then the coordinator converts blue font to black font. The slides becomes then flagged finalized, and the slide is closed until really highly urgent, relevant new information becomes available. There might be a new publication, for example, or something that has been overlooked. And that could be very late. It could be during the public consultation towards the almost very end of the whole process. And then we would actually change the color again. It would be added in red, whatever the new information is, and the process would restart. It's not very often that we need to go through number 7 of these points to finally really finalize a slide. The contributors will be named in the slide set, and that is clinical microbiology, pathology, radiology, infectious diseases, pediatrics, hematology, intensive care, dermatology, pharmacology, and that's it. Unless we forgot a group, then we would add a slide with that new group and that new discipline that we might need to give the best advice and guidance for cryptococcosis. The epidemiology is a first part, as you would expect, in the guideline. And we go for epidemiology by region. And we want to have a world map. Maybe we do regional maps. It depends on what the information we find is best displayed in. We will, of course, refer to recently published guidelines, and that brings us to the diagnosis part or diagnostic part of the guideline. In microbiology, we do populate these tables for the conventional methods first. Let me briefly again lead you through the tables. From the left, it's which population do we refer to? There must be some publication and a certain population. It could be any population if it was mixed and applies to every population thinkable. Then what is the intention? What do we want to reach with our diagnostic measure? And it would be exactly the same for the treatment measures, because a diagnostic test is an intervention as well as a treatment is an intervention, because it changes or has the potential to change the further course of the patient. So after defining the population and the intention and the intervention, we then go for the strength of recommendation and the quality of evidence, and need to support this with a reference. In the very rare cases where there is just no reference for something that we still want to do on a specimen of the patient, then we would actually write down no reference found. And there is another column, the comment, that's for only very essential aspects that should not be lost when we have all the tables finished and start to write the text. Then that's where information has been parked, so to say, that we need to incorporate into the text. That brings us to more microbiology slides. We do have one on serology, one on molecular-based tests, one on point-of-care assays, species identification, of course, susceptibility testing, and we go through more and more of these slides. Another very important aspect in the diagnosis of invasive fungal disease is pathology, including autopsy studies. Then imaging studies, of course, all the radiography or whatever other imaging should be placed here. And now that we accomplished populating all these slides, we will have the ability to assemble from these information on these slides. We will have the ability now to draw a diagnostic pathway if there are all diagnostic options available. A nice flow chart, as you have seen it with other guidelines from our groups. That was if we have all options available, but if we do have restricted options available, we need a flowchart for that situation too. And it might be several flowcharts if there are different sets and settings of limitations that we have to face when diagnosing and treating a patient. Coming to treatment. First of all, prophylaxis. So we follow a strict chronology here. Fever-driven. Is there any fever-driven triggers or treatment decisions? Then they should go on that slide. And as you would expect, the next one is diagnosis-driven. So what can be said of diagnosis-driven treatment on cryptococcosis? Targeted treatment, first line, and then The next is on salvage or second or whatever other line of treatment should go in here. Then we need to come up with recommendations for treatment duration. Often very difficult, it might be individualized, but whatever information we can give and can help our colleagues with should be on that slide. And treatment other, because there will be aspects not covered, I presume, so this is a placeholder. There might be specifics with Cryptococcus, there certainly are specifics for HIV and AIDS patients. There might be specifics for hematology, oncology, solid organ transplant recipients, diabetic patients, maybe yes, maybe no. We will see whether we find specific information for that group. Trauma patients. Children may have special requirements in their first-line treatment, so we want to have that as a separate section in this guideline. And the same is true for salvage treatment. Therapeutic drug monitoring might have a role. If so, you will enter the information here, please. And then there might be adjunctive drugs and general management recommendations. They could go in here. This is kind of a mixed bag, but if we park everything here, we can sort out and bring it into a nice structure at a later time point, as long as the information is always entered in full lines with or without an optional comment. Hyperbaric oxygen, it's in the field of invasive fungal infections. You find it here and there. I'm not sure whether we will find information on hyperbaric oxygen in cryptococcal infection. If not, that might be a slide that is left empty, could be. Financial implications, maybe one slide is not enough, but we want to address them. And brings us to the treatment pathways. All options available flowchart, very similar to the diagnostic flowchart. And then, of course, restricted options only available. And that might be, again, more than one flowchart, because the one or the other drug might not be available, or other limitations, or several drugs not available. So we will see how many flowcharts and pathways we get. We do have authors and contributors from all over the world, so we will get their input in their specific situation, what they are lacking and what are the options that they finally can use and apply. 5 most important unmet needs. I guess that in the setting of cryptococcosis we will have more than 5 most important unmet needs. So this is where you can just write plain text on it, individual sentences or just keywords, whatever comes to your mind, what the 5 most important unmet needs are. We will consolidate that and write a text on the most important unmet needs towards the end of the guideline process, before public consultation, and of course this will all be agreed upon with the contributors and authors. Very similar, the 5 immediate next research questions would be another slide to fill in a very similar fashion. And with that, that's it. And that was easy. It was only 58 or so slides that are the backbone that we will practically follow all the way through during the next year, and add the information, hopefully finalize slides, and then at the very end write text, which would, by the way, be done by a writing group that is the coordinators and others of you, whoever wants to contribute to the writing itself after the slides are done and accomplished is absolutely invited and welcome to do so. And that's it for today. Thank you very much, and hope you enjoy working with the group building the ECMM IDIM guideline on cryptococcosis in the One World, One Guideline program. Thank you very much.